Hi, welcome back. This is Tracy. We're going to finish up with postoperative care, chapter 18 in your IGGI book. We're going to start talking about when postoperative care starts and how we're going to take care of our patients throughout this period. So postoperative care begins when surgery has been completed and our patient is then transferred into the post-anesthesia care unit or PACU. Same-day surgery units, when you're working in same-day surgery, they typically will go to the PACU for a brief period of time and then back to the same-day surgery area. And then patients will be discharged from same-day surgery, or if they require hospitalization post-operatively, then they'll go back to the regular med-surg floor and then be discharged from those areas as well. Typically, with the taking care of the patients during this time, they're going to be monitored very, very closely. You can see in this picture there's a lot of stuff going on, lots of IV drips, things like that. Typically, vital signs are going to be every 5 minutes. We're going to be looking at level of conscious changes, going to be monitoring pulse oximetry, going to be checking those incision dressings. We want to be looking at those very closely, monitoring things very closely, because this is the time that our patients are going to be very fragile and require close monitoring, things like that. The postoperative period will continue after the patient's condition is stabilized. The patient is discharged, and then until they have that follow-up with the surgeon in that postoperative period, that's the length of time that it will be. So sometimes people will be in a quote-unquote postoperative period for several weeks. Maybe they don't see the surgeon for a week, maybe 2 weeks. So you can consider that time from discharge from the operating room all the way through till they're discharged. So let's take a look at this really great mind map. And when you're looking at this, you will see respiratory status is the #1 concern. Oftentimes when patients are extubated, laryngeal spasms can occur during that time. And really the only way to take care of our patients when they have these laryngeal spasms is to initially call for help and get them oxygen, and the nurse anesthetist or anesthesiologist will probably have to come and give them a little bit of Valium, something to cause those muscles to relax so that we don't end up losing that airway. So airway, #1 concern. Take a listen to those lung sounds, especially if you're taking care of patients that have congestive heart failure and we're giving a bunch of IV fluids during surgery, prior to surgery. Be listening to those lung sounds, making sure they stay nice and clear, having our patients cough and deep breathe, watching for that gag reflex. Sometimes patients will have oral airways in, but be looking for all of these different things. So it talks about positioning, suctioning, coughing and deep breathing. Do they need to be on mechanical support? So are they going to be on a ventilator post-operative? So just a few different things to think about. When you are receiving report in the PACU, make sure that you get a good detailed report. And when you look at this little lady right here in her green, they want to know how the patient tolerated it, the type of surgery, the type of anesthetics, results, complications, INOs. So things like that, just make sure that you're getting all of that information so you have a good knowledge of what your patient just went through. When patients wake up in that immediate postoperative period, typically they are forgetful, confused. So we need to make sure that we continue to reorientate them, so letting them know where they are, know that surgery is over with, know they're doing okay, let them know that the surgeon has visited with their family. We try to keep it a fairly quiet environment and explain all the procedures. And sometimes it'll feel like you are explaining the same thing over and over and over, and you might want to strangle your patient, but rest assured, once that anesthetic has worn off, things will get better. When can our client return to the room? See across the bottom of this slide, when vital signs are okay, when they're awake, the dressing looks good, and they can maintain their oxygen saturations. And then make sure, like I said, be checking that incision area for drainage, watching what that looks like. Post-op complications, we had addressed those a little bit in the previous presentation, but so with if you look across the board as far as lungs go, atelectasis, hopefully you all know what atelectasis is. If you don't, take a moment to look it up. But with atelectasis, we'll see dyspnea, tachypnea, decreased breath sounds, asymmetrical chest movement. So this is the importance, prevention of atelectasis, prevention of pneumonia. That's why we need these patients to cough, deep breathe, use their incentive spirometries. We want to get all of those secretions that are sitting in those lungs, get them up, get them moving. Urinary retention, we see urinary retention very, very common with a spinal or epidural medications administration. If our patient is not able to void 8 to 10 hours post-operatively, palpate over the bladder, probably going to do a bladder scan, and then take that evaluation assessment from there and then notify your physician. People that have the spinal anesthetics will oftentimes have a Foley catheter. We leave that Foley catheter in for about 24 hours so that they don't have trouble with this urinary retention. With circulatory pulmonary embolism, shock going to be common. When we're looking at our incision sites, make sure that we don't have any infection. The diabetic patient is going to be at increased risk for infection due to blood glucose levels. We're going to talk about dehiscence and evisceration, gastric dilatation. So are they having continued nausea, vomiting, abdominal distension? And then the paralytic ileus is post-operatively if our patient is unable to pass flatus, have any bowel movements, decrease bowel sounds, those kinds of things be looking for. During the PACU recovery time, our patients will begin their stabilization. It's typically very close to the surgical suite in case something would go wrong and our patient would need to go back into surgery. Adults are typically separated from children. We typically use privacy curtains between patients because there's not just individualized rooms in the PACU, because we want people to be able to move freely, especially during medical emergencies. So we're going to make sure that these patients have access to oxygen, suction equipment, cardiac monitors, pulse oximetries, maybe capnography, airway equipment, and then all emergency drugs that would be necessary for resuscitation. Recently, as you can see on this slide, the Joint Commission's NPSG, which is National Patient Safety Goals, require that anesthesia care providers and the circulating nurses give the PACU nurse verbal handoff reports. In a way that this is important is that we want to have this open line of communication and be able to talk about the patient's condition and what kind of needs they're going to have. So it is a two-way verbal interaction between the health professionals. When the PACU nurse is receiving report, we don't want to have any interruptions. There's usually a standardized way of presenting the information so that every patient is given really pretty much the exact same handoff, or at least the exact same information is included in that handoff. They give time for the receiving nurse to think about the report, to ask any questions, and take time to just get a good understanding of what the patient is going through. Your PACU nurses will have extensive knowledge in advanced cardiac life support. They have very good skilled assessments. They're able to make very quick decisions in emergency scenarios. So if you look at page 285 in your IGGI, on the top of that page, chart 18.1, you'll see best practices for patient safety and quality care. And it does list out a post-operative handoff report. So what I'd like you to do is take a look at that and be cognizant of it. So when we talk about that in class, you'll be able to come up with answers for me. PACU functions for the nurse, she is going to be primary responsibility of assessing our patients. So watching respiratory rates, level of conscious, TPRs, pulse oxes, blood pressures. Want to make sure that she is examining that surgical area. If there's any drainage on that dressing, it's going to be important that that area is outlined, timed, and dated, so everyone is aware of how much drainage is presenting and those types of things. So it's going to be very important to watch those dressings very closely in that PACU. And then she determines when that patient will be ready to be discharged from the PACU using the Alderet score. Post-operative care goals. So these are goals to be able to leave the PACU, but they're also goals for our patients to be discharged from. So we want to make sure first and foremost, that they have excellent respiratory function, that they're using that incentive spirometry, that we have adequate hydration, especially if someone has very thick, tenacious secretions from lungs. For bowel sounds, we typically keep them NPO or ice chips, clear liquid diet until GI function returns. Will they have an NG tube? It's kind of depending on what type of surgery they have. So as our job as nurses to listen to bowel sounds, record those bowel sounds, record passing flatus, record any bowel movements, and then we will be responsible for progressing that diet, because typically what you will see is a physician's order that says progress DAT, so progress diet as tolerates. For management of cardiovascular function, we need to be looking at hemoglobin hematocrit. We're looking at skin color. How are they tolerating activity? Early ambulation is going to be very important for our surgical patients to prevent thrombosis, DVTs, pulmonary embolisms, all those kinds of things. We do want to take a look at fluid and electrolytes. So are they on a continued IV rate? Are they sipping? Are they drinking? Watching those fluid and electrolytes, and then any drainage. And then for comfort, we do want to make sure, it talks about analgesics. So are we looking at the opioids, or are we able to step down to something else? Antiemetics for vomiting and nausea. Hygiene. If they're sweating, diaphoretic, when they first come out of surgery, they have all that scrub solution on them. So let's get them cleaned up, bathe them, get them in a clean gown. You guys all know, it seems like if you take a shower, you feel a little bit better. So at least give them a bed bath, clean them up. And then also promoting as much rest as we can. With our respiratory assessments, biggest thing is, do we have a patent airway? If they have an artificial airway, we need to note that. Sometimes you will see that they have an oral nasal, or they will have an oral airway in, and when the patient wakes up, that's when we determine when to take those airways out. Looking at the rate, pattern, depth, always take a listen to those lung sounds. Watch how they're breathing. Listen for any snoring or stridor. If they have stridor, it would mean obstruction. So then you need to be thinking about getting help. And then respiratory depression or hypoxemia, because you need to consider these patients have had quite a few medications, so we want to be watching that. With the cardiovascular assessment, vital signs is going to be a great way to assess them. We want to ensure that their heart rate, blood pressure return to 10 to 15% of the normal prior to discharging them from PACU. Monitor for VTEs, and we'll talk a little bit more about those, but we really don't want our patients to develop any venous thromboembolus. So be looking at those, watching your cardiac monitor. If they're in a different rhythm than what they were in the preoperative phase, we need to be continuing watching that. Listen to heart sounds, make sure they're still regular if they were regular prior to surgery, and if they were irregular, make sure that that's a consistent finding. Neurologic system. With the neurologic system, we're just going to be assessing our patient's level of consciousness. And as I said, they may seem confused, disoriented, those types of things when they initially wake up. But as time progresses, that will improve. So we do want to make sure that we are taking a look at the neurologic functioning. Compare the patient's baseline neurologic status that was obtained prior to surgery, and make sure that it's comparable with the findings post-operatively. Watch their motor function, sensory function. Are they able to feel? Are they able to breathe independently? And then test for return of sympathetic nervous system tone by gradually elevating the head of the bed, and then watching how that patient reacts. Are they having any orthostatic hypotension changes, or are they able to tolerate that? With our epidural or spinal, we do want to be assessing those dermatomes and the dermatome level. So we're going to be asking our patients if they can feel us touch them, if it's dark, if it's dull, if it's sharp, and how they're able to move. The last thing I want to talk about, you need to be aware of this, is the Alderet scoring. So this is how our patients are decided upon being discharged from the PACU. So they have to have a minimum score of about 6 prior to leaving the PACU. So it takes a look at how can they move, how are they breathing, are they fully awake, and then watching their pulse ox and blood pressures. So I will stop here and we will finish up with one more brief segment on postoperative care.